Recording in progress.
Bismillahirrahmanirrahim. Topic of today is antidepressants in primary practice. And so, in antidepressants in primary care, what a GP should know. And my main source of the today's presentation is the Maudsley prescribing guidelines. So I will try to summarize what a GP should know about the use of antidepressants. Now I will not go into the diagnostics, that how to diagnose depression or the indications, etc. So onset of action. It is widely held. Now I'm reading from the page number 307 of the Maudsley prescribing guidelines. So it says that it's widely held that antidepressants do not exert their effect for 2 to 4 weeks. This is a myth. All antidepressants show a pattern of response where the rate of improvement is highest during week 1 to 2 and the lowest during weeks 4 to 6. Statistical separation from placebo is seen at 2 to 4 weeks in single trials, and thus the idea originated that it is something like uh, that it is something like that it takes at least the uh, 4 to 6 weeks to act. So because this idea came from clinical trials, and I have seen, and mostly, I mean, I agree that mostly we see significant effect in 2 to 3 weeks, but there are instances, and even in my practice there were occasions when we gave the antidepressants, and it caused some improvement straight away in the patient. So don't say that it's a placebo effect or something. So it can cause improvement straight away. That is the first thing in the onset of action. Now, the choice of antidepressants and relative side effects. So today my focus is onto the GPs. Like I'm talking to the GPs mainly. So I would say to my GP colleagues that they usually prescribe escitalopram as the first line, and previously it was citalopram. So, but generally, the most favored antidepressant in this secondary care, both in the UK and Ireland, what I see, the most prescribed medication is sertraline. The reason for that is that it is cardio safe, so it does not cause any QTC prolongation, and it is thus safe in cardiac patient, it's safe in elderly, it is safe in pregnancy, it is safe in breastfeeding. So my recommendation to the GPs will be use sertraline, and not not escitalopram as the first line. Escitalopram is a good medication, but the drawback is that you can't go above 20 milligrams, and there is a risk of QTC prolongation above the 20 milligrams dose. So that's why it's not used beyond that dose. although 30 milligrams can be more effective than 20 milligrams. Same with citalopram, you can't go above 40 milligrams, although 60 milligrams can be much more effective than 40 milligrams. So that is the limitation. Otherwise, both are excellent antidepressants, citalopram and escitalopram, but due to the QTC prolongation risk and the BNF limits of the dose, that it must be below 20 milligrams in case of escitalopram, and it must be below the 40 milligrams in case of citalopram. So because of that, I prefer, and we all clinicians, most of clinicians in secondary care now prefer sertraline. The other thing, the other medication which is my favorite is the fluoxetine. So fluoxetine is also quite good, and it is not as safe as sertraline in cardiac patients, but it is safe enough. Even paroxetine is safe, but the problem with paroxetine is that you have to give like you when you're coming off paroxetine, you have to taper it very carefully, because the withdrawal effects or the discontinuation effects of paroxetine are not easy to manage. So therefore, paroxetine uh, I won't recommend to the GPs to use paroxetine because of the discontinuation effects. And even in the secondary care, we don't use it much, but in selected cases, yes, we do. So when you are discontinuing paroxetine, the ideal way to discontinue it or stop it, to convert it to equivalent dose or almost equal dose of fluoxetine, and then discontinue it, because fluoxetine has a very long half-life. Other thing is fluoxetine, which goes in favor of fluoxetine, is that that fluoxetine is quite good in the it has a long half life. So if the patient misses a day or two, you know, there will be some fluoxetine still in the system. And another thing which I have observed, it's the first line in adolescents, and when I tried that fluoxetine in adolescents, I in my own clinical practice, it was better than sertraline, because in adolescents, due to the long half-life, it is better tolerated, and it has a calming effect as compared to sertraline, while sertraline can cause some irritability in the first few weeks. So they are both good in adolescents, but the first line is fluoxetine, and there is a reason for that. So among SSRIs, I would say that among SSRIs, I would say that the better choice is something like the fluoxetine or sertraline. Now, SNRIs, the GPs often jump to SNRIs, Duloxetine or Venlafaxine. Well, Duloxetine, if you have a woman with a gynecological pelvic pain plus depression, then you can go ahead with the Duloxetine as the first line. But otherwise, I won't recommend that. So Venlafaxine, I won't recommend GPs to be using as first line, but as the second line, yes. And another very good second line agent, I would say Vortioxetine. So Vortioxetine can be used as a second line, and some GPs may use it as a first line. I've no problem. The only thing is that it can cause nausea in the first few weeks, so just beware of that side effects, especially of nausea, and maybe you might have to use antiemetics in the first 3 weeks. So build it very, very gradually, but it is also a good first or second line uh, agent. Uh, Other thing is mirtazapine. Mirtazapine can be first line agent in cases where the patient is not eating or drinking well. So in those cases, mirtazapine can be a good option, and you can use mirtazapine. But in all other cases, beware of the side effect of weight gain. So try not to use mirtazapine, and if you are using, give them clear instructions that that the weight gain will be an issue. Other thing is trazodone. I won't use it in primary practice, but in the secondary practice we do. The other medication is agomelatine. Again, it has to be prescribed in the secondary practice, but in case if you end up starting it in primary practice, it is good for mild to moderate depression, not for very severe. Can be used as an adjunct. The problem is liver function tests. So do the LFTs. Uh, there's a specific parameter in the Maudsley prescribing guidelines that you do it at first at first at the baseline, then at 3 weeks, then at 6 weeks, then at 12 weeks, and then you do it every 3 months, which is like every 12 weeks, in other words. Uh, so uh, and maybe every 3 to 6 months you have to monitor. And recently one of my patients, they developed uh, this disturbance after 3 years of normal LFTs. I don't know if it is being caused by agomelatine or not. So that's why you will see agomelatine being prescribed by the psychiatrists. But that if you see and if you are prescribing it, you're continuing the prescription, please do monitor it. The other thing is lithium. Lithium for adjunct depression, or for the as a mood stabilizer. If you are seeing any patient on lithium, like, you don't start it at all in the primary care, but you will have to monitor in the secondary care. So uh, anybody on more than 10 years of lithium, just be prepared that their kidney function is going downhill, and you have to monitor the kidney function very, very meticulously, and be very vigilant about the kidney functions, because you might have to discontinue lithium. So it should not be, in my opinion, it shouldn't be given more than 10 years. But if it is being given, then even be more meticulous about the kidney function. That is my main concern. The other concern is toxicity. The toxicity can happen on lithium, especially, like, I'm recording this in the month of May, and in May, June, July, August, these months, the patients can develop toxicity quite easily. So be very, very careful in prescribing lithium, and do the U and E's. In anybody on lithium, do the U and E's in like every 3 to 4 months, or maximum every 6 months. But in the summer season, ask them to drink more and more water and not to get dehydrated. Otherwise they will get otherwise they can get lithium toxicity. So uh, this is about the choice of antidepressants. The other thing is tricyclics. So there is a very good tricyclic agent used by the GPs, and I have no concern. I'm happy that the GP prescribed that tricyclic in micro doses for pain, and that's a good thing. Amitriptyline, but be very low in the doses, and you do already. So 10 milligrams, 20 milligrams, 25 milligrams, 30 milligrams, maximum 50 milligrams. Don't go above 50 milligrams, because uh, if the patient takes an overdose, that can be very lethal. So be very low in the doses of tricyclics, and don't give tricyclics to any patient with the overdose risk. As long as the patient is not taking an overdose, then you can use low doses, and only psychiatrists should give the higher doses if required. I have only a handful of patients who will be on high dose of like therapeutic dose of amitriptyline. Otherwise, they are on micro doses, which works for sleep, which works for pain, and which may work for anxiety to a little bit. So uh, that's something about antidepressant. Then the other thing. So I've explained to you one thing about the QTC prolongation. QTC prolongation, which is a very important side effect. The other side effects to consider practically, one is the sexual dysfunction. So if there is especially in males, although libido can be decreased in females as well on SSRIs, so be careful about even on venlafaxine. So be very careful. I think vortioxetine may be relatively better, but I don't think that it will be entirely like fully suitable, even like or free of devoid of that side effect. I don't think there will be some side effect. The other thing is mirtazapine may be a little bit better, and then trazodone maybe, but trazodone I won't recommend GPs to use it, especially in the males, because it can cause the other way around. It can cause priapism. So try to stay away from trazodone and let psychiatrists prescribe that. So then the GI symptoms. So you just say that take the SSRIs with the milk or with the food, and especially in the morning time. Otherwise, they can cause acidity. Hyponatremia is another relatively uncommon side effect, but if that is occurring, then mirtazapine is better than SSRIs. And then uh, MAO inhibitors we don't use, so I won't even discuss that. Drug interactions. So drug interactions, they're not very important. Drug interactions, for like maybe avoid the grapefruit juice. That's one thing. Then pharmacodynamic interaction with aspirin. If the patient is on aspirin, they have an extra antiplatelet effect for being on SSRIs, and they may increase the bleeding risk. So that's what you need to balance about the bleeding risk on SSRIs. Uh, Suicidality on antidepressants. So especially on the sertraline in adolescents, the suicidal behavior can go worse, and that's why I prefer fluoxetine. On any antidepressant, any SSRIs in adolescents can cause this. You must tell the adolescents and their parents that in the initial few weeks it can cause agitation, or it can increase the suicidal behavior. It's a temporary thing, it will settle with the time, so keep taking the medication. But it is must it uh, it's a something that is you must mention to them in adolescents especially. So and it's relatively less with fluoxetine, but even with the fluoxetine, this
Recording in progress.
this thing can happen. And then uh, the other thing is duration of treatment. So they say in modestly prescribing guidelines should be given 6 to 9 months after recovery from a single episode. And my personal opinion, the longer the better. If the patient is doesn't want to stop, or is the patient is not bothered about keep taking, just let them keep taking. If they are really adamant that they want to stop, then 6 to 9 months after the recovery of the first episode. But if it is a multi-episodic depression, recurrent depression, then in that case you need to continue the antidepressant for a long time, and it could be 3 years, 4 years, 5 years. So we are talking about years that it should continue, and it shouldn't be because there's a clear risk of relapse, so in recurrent multi-episodic depression. So it's almost a lifelong in the multi-episodic. Uh, then I come to then there is a table about the doses of the antidepressants. So generally we start on the lowest dose, which is generally on 1/4 of the total daily dose. So Escitalopram, it will be 5 milligrams, Sertraline, it will be 50 milligrams, and Fluoxetine may be 20 milligrams, 1/3 of the total daily dose. It used to be 80 milligrams at some time, and that's why the 1/4 becomes 20. But now BNF says they don't go above 60. There's one exception, especially in the obsessive compulsive disorders. At times, you might have to go to 80 or 100 milligrams. So, just that is one exception that with the uh, with this medication, like with this condition, OCD. Otherwise, all the doses are mentioned. So you wait for a few weeks before increasing the dose. But if the depression is very severe, then do it quickly after 1 week. Like sertraline, start at 50 milligrams. Depression is very severe, go to 100 milligrams after 1 week, and then maybe stay for another 3 or 4 weeks on 100 milligrams. If it is still very worse, may even go up to 150 milligrams, then hold. Otherwise, stay on the minimum or effective dose. Then uh, the safest tricyclic is Lofepramine, but unfortunately it's taken off market. But just for your clinical knowledge, safest tricyclic is Lofepramine with minimum cardiac effects. Uh, Discuss choice of drug with the patient, and also tell them the main common side effects, which as I have mentioned. Otherwise, there are loads of side effects mentioned in the BNF. If you start telling them all, they will get confused. So you must give them a written handout, a fact sheet about all the side effects But when you are mention the most common or the most concerning side effects. And it's up to you if you want to mention all, that is also all right. But the most common must be given. And so and then there is a table on the page number 314 on the of the Maudsley prescribing guidelines, 14th edition, that how you switch and when to switch. So I would say that the 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 thing with the switching is that that you do not you like you do the switch or only when the medication is not working at all for about 4 to 5 weeks, no effect. If there is some effect, the modern research or literature shows that the effect can be seen from the very first days, very first week. So if the effect is shown, then continue increasing the dose. But if there is no effect, then maybe switch to another antidepressant for 4 to 5 weeks. Or if the drug is not working at a very maximum therapeutic dose, then you can switch. Venlafaxine is a good because it can go very high in doses. But one thing the GPs must know on venlafaxine is that it it can cause hypertension. So beware of hypertension side effect on venlafaxine and be very careful. So anybody on venlafaxine or duloxetine, do check their blood pressure each time. You are GPs, it's your take. You can either decrease the dose if there is a hypertension, or if there's a family history of hypertension, or there are other risk factors for hypertension, then start them on an antihypertensive and continue with venlafaxine. But you must check. Similarly, ECG should also be monitored, especially with venlafaxine, but it's not a must thing with the antidepressant. However, if you are prescribing citalopram or escitalopram, I would mention that I would say that you must monitor ECG with these medications. Now, vortioxetine here, it is mentioned as a third choice antidepressant. So it's up to you. You can use it as a first line, second line, or third line. But at Maudsley prescribing guideline, it is said that it is a third line after venlafaxine and mirtazapine, and also the duloxetine. Now, management of treatment resistant depression. So treatment resistant depression, generally it is a topic of the secondary care and can be taught separately. But what you will see, or if you are in, you can add some low dose of aripiprazole or some low dose of quetiapine if in case of resistant depression, but you must refer those cases to the secondary care, and they may start them on lithium. I also use buspirone sometimes in addition to the SSRIs, but buspirone works best in mild to moderate depression which is resistant to the treatment. If it is very severe, then maybe lithium is required. Do not combine SSRI plus SNRI. The combination antidepressants, they can be SSRI plus agomelatine, SNRI plus agomelatine,
or SSRI plus mirtazapine, SNRI plus mirtazapine. This is what you can do in the primary practice. But doing uh, if you are doing that in the primary practice, like try to avoid agomelatine if you can. And because of the monitoring of liver function tests, it should come from secondary care. But if you are prescribing, then you have to monitor it. T3 augmentation is another thing. So psychiatrist may sometimes augment it on T3 because the recent evidence is the uh, kind of subclinical hypothyroidism in which depression is a symptom and T4 may be normal while T3 levels may be low, or sometimes even with the normal T3 and T4 levels there could be a cerebral hypothyroidism. That means the cerebral deficiency of T3 in the brain. So if you give a bit of T3 so that the thyroid function tests remain in the normal range, they don't go above the normal range, then in that case you can prescribe T3. So you have to monitor thyroid function very closely if you are prescribing T3, that neither of T3 or T4 should cross the normal range. If it is in upper normal range, that is fine. So even you can start without hypothyroidism and keep it in the upper normal range, and then you can prescribe T3. T4, no, because the problem is not hypothyroidism. The problem can sometimes be conversion of T4 into T3. So that is why uh, it is something to be considered. The T3 may be effective in case of resistant depression. I've never tried, but I will definitely consider at times. Other options are ketamine. As ketamine, mm, I won't use much because it's abuse potential and also the monitoring for hypertension in the clinic. So for these I won't use. Lamotrigine and another. Now lamotrigine I tend not to use very much, but if I try to use lamotrigine for resistant depression, I use it in very very low doses, like 25 milligrams for a month. And if there is no skin rash, then I start building it up 25 milligrams every 2 weeks. So even the 50 milligrams may be effective. So sometimes when I start, then I keep the dose low deliberately for a long time because the patient may get a skin rash or it may turn out into the generalized skin rash, or sometimes uh, sometime the generalized erythema and Steven Johnson syndrome. So that's why I uncommonly use, but it is nearly very close to efficacy in to lithium. Uh, so it's comparable, not as effective, but it is closer enough. So lamotrigine is another good option. Then the ECT, which is done in the secondary care or tertiary care only. Uh, then there are other options, so I won't go through. One option which makes sense, dexamethasone, 3 to 4 milligrams per day, limited data. But again, I won't go near that option because it won't only cure the resistant depression, it can even it can cause steroid induced mania, which may be very difficult to treat. So but that's something which is written in the book. Then it's pindolol, risperidone, etc. Zinc even. So then there's a chapter on ketamine. I would psychotic depression. So depression with psychotic symptoms. Sometimes the depression goes away, psychotic symptoms still persist. So that's why in psychotic symptoms mostly antipsychotic is used. In very few cases, the psychotic depression may go away only on antidepressants, but mostly psychotic antipsychotic is used, and sometimes antipsychotic can be needed for a very long time, because even if you stop the psychotic, the like if you stop the antipsychotic, the psychosis will relapse, and psychosis may continue irrespective of depression. And sometimes it may be so persistent. So some people with psychotic depression need long term antipsychotics. Then the switching antidepressants. So there's a Canadian website told by my friend Dr. Niazi. So it's switchrx.com. Switchrx.com. It is good for like telling you how to switch, but general rule for switching is cross taper. So you introduce one drug, you started reducing the first one, and you build up the second one. So that is the rule of thumb, but sometimes there may be exceptions for that. So you do go to that website. Another website is medichec.com. medichec.com. There's no K. So medichec.com, medichec.com, and it will tell you about all the side effects of the psychotropics, especially the anticholinergic effects, but mostly all other side effects as well. So it takes into account many side effects now in the modern version of the website. Initially it started with only anticholinergic side effects. Then there is a table on 338 page about the how to switch to another antidepressant. The rule of thumb is cross tapering. Now, how to stop antidepressants? How to stop antidepressants? It is in a hyperbolic way. That means like a bowl. So the bowl is coming like that, and becoming flat like that. So it is like a sandbag with a hole. So more and more sand will pass in the beginning, especially if you're squeezing and at the same time, and less sand will pass through in the end. So that means and it is also related to the first order kinetics as well. So what you do is you decrease the medication quite quickly in the beginning, but more slowly towards the end. For example, patient is on 200 milligrams of sertraline. They want to come off. You cut it down to 150 for 2 weeks. Then you cut it down to 100 milligrams for 2 weeks. Then, now, I'm generally much more slower than this, but I'm giving you an example of the hyperbolic reduction. So what you do is that after that, any reduction you need to be very slow. So now 100 milligrams, you continue for 2 months on 100 milligrams.
then you reduce it to 50 milligrams, then you continue 4 months on 50 milligrams, and then maybe after 4 months you may decide to continue on 25 milligrams for another 4 months. So the rate of reduction is much more slower in the end. So it is much faster in the beginning and it is much slower towards the end. Faster in the beginning, slower towards the end. And there is one formula which you can remember, the formula of 1/8. It's a rough guide, especially it is set for benzodiazepines. So 1/8 of the remaining dose, 1/8 of the remaining dose every 15 days, 1/8 of the remaining dose every 15 days. So let's say that you are like 64 milligrams, for example. So you are taking in the 2 weeks, there's a 64 milligrams dose. So in 2 weeks you take out the 8 milligrams dose. So the remaining will be 56 milligrams. So now you will take 7 milligrams every 2 weeks. Then it will be and then maybe 6 milligrams every 2 weeks, then 4 milligrams every 2 weeks, and in the end you might be coming to the like 1 milligrams every 2 weeks, half a milligram every 2 weeks, maybe a quarter of a milligram every 2 weeks. So that's an example, 1/8 of the remaining dose every 2 weeks. That is also one way of discontinuation of any psychotropics, whether it is like especially the benzodiazepines. And then antidepressants, antipsychotic, they can go in the hyperbolic way. Antidepressant withdrawal symptoms. So there are many symptoms mentioned, and I think I recorded one lecture or on that, but there are withdrawal symptoms, but they are most prominent with the venlafaxine and paroxetine. So if you are withdrawing venlafaxine, be very, very slow and go with the hyperbolic method, and be very slow towards the end, and you might have to give some quetiapine or maybe some benzodiazepines to overcome these side effects, these discontinuation symptoms. So be very careful of those. So there are SSRI withdrawal symptoms. They can be in sensory domain, somatic domain, affective symptoms, or disequilibrium, sleep disturbance, gastrointestinal symptoms, or sexual symptoms, or cognitive symptoms. So the rule is try not to use the paroxetine, and if you are using paroxetine, switch it to fluoxetine. If you are using venlafaxine, even then if it is better that you may consider switching it to fluoxetine, so that there is something going in patient's system. And because fluoxetine has a very long half-life, then you can taper it off easily as compared to any other drugs. The rule is that longer the half-life of any drug, including benzodiazepines, easier to taper it without any discontinuation symptoms. So stopping antidepressants, I've told you about the parabolic method. It is given in the 349 page of the Maudsley prescribing guidelines. Now I'm going and then there is an example reduction as well. And then electroconvulsive therapy and the psychotropic drugs, benzodiazepines, SSRIs, venlafaxine, mirtazapine, duloxetine, TCAs. Uh, so generally, if you're giving ECT, then you continue with the uh, these medications. Psychostimulants in depression, again, it is something related to secondary care. They may use a bit of modafinil, but again, if you are using any stimulants, even for the comorbid ADHD, then be careful. Do not use them with venlafaxine. And if you are using with any antidepressant or for depression itself, or even if you are using the bupropion, then monitor the blood pressure with the stimulant. Again, I will go for sertraline, not with citalopram or anything else. Sertraline will be the most suitable because of its cardiac safety. And then the so that's about the post-stroke depression. And then the next chapter here is the antidepressants alternate routes of administration. So sometimes they say in the Maudsley prescribing guidelines that fluoxetine liquid can be used sublingually in some medically compromised depressed patients. So that is worth consideration. Uh, if if you can put it underneath the tongue of the patient, fluoxetine liquid. Similarly, ketamine injection, then the buccal selegiline. So they are the higher level discussions. Again, rectal amitriptyline, transdermal amitriptyline, intranasal escitalopram. So they are high level discussions. I won't go near that. And I've told you about the antidepressant prophylaxis. So antidepressants are more important in prophylaxis than treatment, and that's why I say 6 to 9 months after the first episode is over. So the first episode took 6 months to get better, then you give at least 9 months in addition to that, so that the total may be a year and a quarter maybe in that case. And if it is a multi-episodic depression, then maybe 3 to 5 years, or it could even be longer and longer than that, sometimes lifelong. Because whenever uh, you try to stop the antidepressant, you get a relapse. Now, drug interactions with antidepressants. Drug interactions are they are mentioned in the on the 378-379 page of the Maudsley prescribing guidelines, 14th edition. But in case of antidepressants, they're not like very important. They are important, but they are even more important in case of antipsychotics. Cardiac effects. So the main cardiac effect is the QTC prolongation, especially in case of citalopram and escitalopram. And therefore fluoxetine, paroxetine, and sertraline are relatively safer in this case. There's also one more, fluvoxamine. We don't use it because it has to be given on a BD regime, like twice a day, unless they come with a XR regimen, XR preparation. We don't use it. So I haven't used Fevrin or fluvoxamine for ages, but it's good for OCD, and it's Yeah, and then the antidepressants induced hyponatremia. So if that is a problem, then maybe uh, try them on mirtazapine, on alternate antidepressant. Hyperprolactinemia, very rare. Diabetes mellitus, generally they cause hypoglycemia, but we have observed sometimes any antidepressant can lead to weight gain, and if there is a family history of diabetes, then they can predispose a person to diabetes. Especially the mirtazapine can cause full-blown metabolic syndrome because it's associated with weight gain, uh, and so there can be hyperglycemia, hypercholesterolemia as well. In addition, hypertension. So that's why if you are using mirtazapine, be very careful uh, about the metabolic syndrome, because it can cause uh, metabolic syndrome. And sexual dysfunction, I've already talked about, that this is something to be aware of, and sometimes you have to reduce the dose, sometimes you have to switch to mirtazapine, or sometimes you have to give sildenafil in addition. SSRIs and bleeding, so generally they can be combined with aspirin, but you need to discuss with the GP. Maybe they are better off without aspirin. Not that, like, you need to discuss that with the cardiologist, because sometimes they are enough for the antiplatelet effect, and sometimes you need two antiplatelets, and then aspirin plus SSRI are required, especially in the ischemic heart disease or ischemic stroke. But it can cause gastrointestinal bleeding. It can also cause increase the chances of intracranial or intracerebral hemorrhage. So be mindful of that. Gynecological and obstetrical hemorrhage can also occur with the SSRI, abnormal vaginal bleeding, postpartum hemorrhage, surgical and postoperative bleeding. So just be careful about that. And sometimes mirtazapine or bupropion can be tried instead of SSRIs, which are which are not acting on serotonin. Uh, Especially bupropion is pure kind of working on dopamine and noradrenaline, but not on serotonin. So these are the alternative to SSRIs and SNRIs where there is a bleeding problem. For example, diverticulitis, diverticulosis, or menorrhagia, or a similar kind of bleeding disorders. In those cases, you don't use the SSRIs. St. John's wort, some patients will come to you, they are using St. John's wort, but it is a potent inducer of cytochrome P4 system, P450 system, and can interact with the oral contraceptives, and oral contraceptives may fail, and that may result in pregnancy. So you need to be very clear to them about this fact. Then the other thing is anxiety spectrum disorders. So this was mainly about the uh, depression and antidepressants. Anxiety spectrum disorder, if you're using benzodiazepines, be confined to only a few weeks, maximum 4 weeks. There may be patients who may require long-term benzodiazepines. You put the ball in psychiatrist's court and let the psychiatrist decide whether the patient needs a long-term benzo or not. Otherwise, be very brief in their prescription. If the psychiatrist says yes, then in selected cases, you may need long-term benzodiazepines, especially with the catatonia. In catatonia, the best antidepressant which works, but the best benzodiazepines which works is lorazepam. Nothing else works. So in catatonia, it will be only lorazepam. Sometimes SSRIs and SNRIs, which are used the for the anxiety spectrum disorders as well. And sometimes you can add mirtazapine or use mirtazapine. Sometimes unofficial use of quetiapine can be very effective. Pregabalin is effective, but it has a big time street value, so it should be regarded same as benzodiazepines. So don't try to use pregabalin. If you have to use, then try SSRIs, maybe buspirone, maybe quetiapine, psychological approaches, and then OCD. I've already mentioned that you need very high doses of the antidepressants plus CBT. So we are on to the 429 pages. Post-traumatic stress disorders. So mirtazapine generally works well, but sertraline is also quite good in post-traumatic stress disorder. And then maybe quetiapine, or sometimes if there are very like vivid symptoms, then maybe olanzapine, but rest that decision for psychiatrists, because generally quetiapine, mirtazapine or SSRIs, they should be okay in the primary care. But if you are starting anyone on quetiapine, make sure that the psychiatrist in your area is happy for you to prescribe any antipsychotics. If you are starting anyone on antipsychotics, please make sure that you do the ECG before prescribing antipsychotic, and monitor ECG on any patient on antipsychotic on a yearly basis. So, and post-traumatic stress disorder patients, they can misuse alcohol and they can misuse benzodiazepines. So try to keep them away from benzodiazepines if you can. Then there's social phobia, then and then the benzodiazepines in the treatment of psychiatric disorders. So yeah, sometimes they can be used in long term, but mostly 4 to 5 weeks is the maximum. So try not to use more than that in the GP practice. Then the benzodiazepines in the detoxification. So you know how the Librium or the chlordiazepoxide detoxification works. So then the tapering off of the benzodiazepines, you become quicker in the beginning to taper off and slow in the end, and 1/8 of the total daily dose after every 15 days. That's also a rule of thumb or rule from the previous guidelines. That is one way. Now another thing I would say, that when you start an antidepressant, it should be the other way from the tapering. In the tapering down, you were fast in the beginning and slow towards the end. Fast in the beginning and slow towards the end in tapering down. In tapering up, it is the other way round. You are very slow in the beginning and you can be relatively faster towards the end. So sometimes you have to start with only 10 milligrams of citalopram
or maybe 10 milligrams of fluoxetine, uh, or 5 milligrams of escitalopram, 25 milligrams of sertraline. Then you increase it gradually in the beginning, but in the later you can make 50 milligrams increments easily. So be slow, start low, go slow, start low, go slow. That is a rule of thumb for antipsychotics, antidepressants, everything. So uh, 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 and also the diazepam is a longer, uh, it's a long long half life anti the benzodiazepine. So if you are tapering off somebody on lorazepam or Xanax, alprazolam for years and years, then maybe uh, go very slow, maybe change it to diazepam in the beginning, or change to clonazepam, and then go slow in terms of tapering it down and stopping it and gradually discontinuing it. So it's the same way you switch the antidepressant to fluoxetine. In case of benzodiazepine, you may switch to diazepam or clonazepam if you are tapering it down. And yeah, sometimes benzodiazepines can cause disinhibition, so be aware of that, especially in case of the beware of that especially in case of sometimes the children and adolescents, sometimes in people with learning disability, sometimes people with old age, people with dementia. They can get easily disinhibited on benzodiazepines, so be very careful. So that's about the my discussion about the antidepressants. If there are any questions, you may ask in the comment box, or if you have my number or my email address, you can email me. My email address is kamran.shaikh@yahoo.com. Thank you very much. Allah Hafiz.